Hi, everybody. Welcome to Vascupedia Views and to an amazing Vascupedia Shockweek. 3 episodes with live cases, challenging discussions, and important technical tips and tricks about the use of shockwave in large vessels. In CLTI patients, finally an episode about the use of shockwave during TIVAR or TAVI and how shockwave facilitates the delivery of the endograft will take place during this week. Today, it is the first episode about large vessels, and we mean CFA and iliac vessels. And I have the honor to moderate a unique, let's say, episode with having 3 key opinion leaders together with me. And of course, we would like to have you very active and interactive during this episode. Please send all of the questions that you have. We want to challenge these 3 experts, and I'm going to try to cover all of the questions that you're going to send. So let me introduce our key opinion leaders, starting with Dr. Elias Nori. He's the head of interventional angiology at Bad Krozingen in Germany. Dr. Nori will perform a very interesting live case, step by step, with a shockwave in the iliac arteries from his center in Germany. We're gonna connect with him in a few minutes, and during the live case and afterwards, we're gonna discuss all indications, important technical aspects of the shockwave technology in the iliac arteries and the SFA, with 2 renowned guests, Dr. Frank Arko, vascular surgeon and director of the St. Gerhard Vascular Institute at Charlotte, North Carolina in the United States, and Professor Raphael Coscas, vascular surgeon at Ambroise Paris Hospital in Paris, France. Gentlemen, welcome to Vascupedia Shockweek, and thank you for accepting the invitation. Moreover, I would like to thank Shockwave Company for sponsoring all the episodes and supporting the Vascupedia activities. Now, let's begin with a presentation of the case of Dr. Nori.
Hello, Theo. Dear colleagues,
Elias.
Do you hear me?
We can hear you very well. Please go forward with your presentation.
Perfect. Let me introduce my team here. I'm here with Jessica, who will assist me today during this case. Dear colleagues, it's my pleasure to present a live case today. And let me start with the live case presentation. Sebastiano, would you show now the presentation, please?
The presentation is already.
It is.
Yeah.
Okay. We have here's a 76 years old male patient with a peripheral arterial obstructive disease, according to Rutherford 3 on the left side, with a typical calf claudication with a walking capacity of 150 to 200 meters. He was already treated just a few weeks ago in the right common iliac and external iliac artery, as well as in the common femoral artery. But also he was treated 6 years ago with a stent angioplasty of the left common and iliac artery, but also in the SFA. He has also a coronary artery disease. There was performed a PCI with drug-eluting stent of the right coronary artery in January of this year. So he has also atrial fibrillation, which requires apixaban, which is interrupted from yesterday. And his risk factors are former nicotine abuse, hyperlipoproteinemia, and atrial hypertension. The next slide, please. So the non-invasive examination showed at the right side an ABI of 0.8 and the left side 0.4. And the duplex scan showed, as you can see, a peak systolic velocity of the common femoral artery, more than 4 meters per second. The SFA, but also profunda, are patent, but at the distal part of SFA is a second stenosis or subtotal occlusion. CT scan, can you see it now? So there is a lot of calcium of the left CFA. And the next slide shows now the angiography of the left femoropopliteal artery You can see a lot of calcium in the CFA. There is a high-grade stenosis or subtotal occlusion, and
Next
the
slide.
distal part of A.
Yes, perfect. We can see
Also,
now.
okay, a high-grade stenosis. So next slide, please. The treatment strategy. So my treatment strategy is I have already placed a 7 French crossover sheaths from the right CFA to the left CFA. I will take a 0.35 or 14-inch guiding wire. If necessary, maybe I would make a pre-dilatation. And the next step is to make a vessel preparation with a Shockwave lithotripsy followed by DCB. If there is a residual stenosis, so I will cover this with a lesion, but we will see it in the end of this procedure. Next slide, please. Oh, we can switch now to the live screen. Is there, as first, any comments or any questions?
Elias, let's see what the people have voted for these cases, because we have asked them if they're going to do an open or an endo repair. Please,
Okay.
let's see the results of the first question. And then we're going to see the second one, what would they have done as a primary treatment in case of endo repair. So please give us the results. So until then, Rafael, you have also, here we have the first results. So 67%, they would use an endo repair. So either we have a lot of interventional radiologists and angiologists here, or we are missing something, because actually as a vascular surgeon, I would have say 67% open surgery. Frank, do you think that we're going to have now, we have convinced, or the results and the evidence regarding IVL and other technologies have convinced the majority of the people to start for an endo first repair in CFA?
I don't know that we have the data yet to sort of support that. I do find myself using a little bit more of an endo approach for the common femoral artery and the endarterectomy. This fella is, he's got a lot of comorbidities. He's elderly. I don't think it's unreasonable. He's got pretty good runoff. The thing I think we miss a little bit is what's the long-term durability going to be with this repair. I think intra-procedural complications, there's a lot of concern that the profunda gets shut off, or there's a lot of embolization in these cases. Certainly hasn't come to fruition with the cases that I've done. But the common femoral endarterectomy, from my standpoint, is an operation that is sort of associated with a lot of the operation's not difficult, but the recovery from it, I think, if we're honest, is not the easiest operation to recover from. It's in an area that's got a lot of movement. It's not the cleanest area, and I think there's a real significant risk of wound infections or slow healing that really affect an elderly individual's quality of life.
Perfect. Let's see the second question before we have Elias starting with his case. So we see 50% we're going to use a atherectomy. Oh my God. And 25% IVL. So the question is for you, Rafael, and then for you, Elias. First of all, Rafael, how do you explain this result? Do we have more evidence about atherectomy than IVL?
I don't think we have a lot of evidence about atherectomy, especially in this location, but and especially in comparative study, we have some kind of studies, as you know, but not enough to say that it's the first line approach. I would not go for atherectomy because here we have a profunda that is patent and also SFA that is patent. So it's complicated to know where should we put the filter and all these questions. So I would prefer IVL because there is very little embolization with IVL, and it's a CFA lesion not extended to bifurcation. So it's quite a straightforward case, in fact, with a single balloon.
Perfect. Let's go back now to Elias. Elias, you have now a big challenge, not only to open the vessel, but to convince around, let's say, 75% of the people that IVL is the best treatment strategy. So please convince us.
Okay, thank you to you. So can we switch now, please, to the live screen? Oh, perfect. So as you can see, this is the first angiography, just a native without contrast media. There is a lot of calcium in the CFA in the external iliac artery, but also in the SFA in profunda. And the angiography showed what we already see. There is a high-grade stenosis of the CFA, and there is a patent bifurcation. And that means that's a very nice and good option for IVL. It is also an option to make an atherectomy, but in my opinion is in this case, it is first a heavy calcification, it has a heavy calcified lesion. It's a relatively a big vessel. And of course, we need a protection device. And as already mentioned by Professor Coscas, the rate of embolization for this kind of lesions after atherectomy is very high. That means so we have to use a protection device. But let me show you the next step. That's the middle and distal part of the SFA. As you can see, there is a lot of calcium, and there is a eccentric high-grade stenosis. So it's the tandem stenosis distal from the old stent, which looks very nice, but at the distal part from the stent in the SFA, there are 2 or 3 stenoses. And the next angio shows a chronic occlusion of the popliteal artery, which is a very nice, very well a nice collateralization of the popliteal artery with reconstitution of the below the knee arteries via anterior tibial artery and posterior tibial artery. So the treatment strategy in this case is to treat as first the CFA and SFA. In this case, I would not open or recanalize the popliteal artery in this session because it's a chronic occlusion. There is very well collateralized, and in my opinion, it would be more than enough for a patient with a cloudy cacho to treat the SFA and CFA. So the next step.
Elias, 1 second.
Comments?
Everybody agrees with this strategy, guys. Frank?
Yeah, I think it's reasonable if that's a high-grade stenosis. I think the velocities were 400 centimeters per second. That popliteal, you know, the long-term duration and patency of it may not be great. So I would probably, you know, fix the inflow, see how he does. If he's got, you know, marked improvement, great. If he doesn't, then you can always come back and, you know, fix the popliteal.
Yeah, exactly.
Elias, please
Dr.
go.
Nouri, can I ask you a question?
Yes.
Do you have the diameters of the CFA and SFA?
Yeah, so this SFA has around about 6.5 to 7 millimeter, and CFA had a 7.3, 7.4 millimeter. That means, so that's another point of question for our discussion, which size of shockwave balloon catheter should we use in this lesion? But let me show the next step, and then we can discuss about the sizing of the shockwave. So as you can see, the passage of the CFA was not really so challenging, but the stenosis of the SFA was very tight. But it was possible to go intraluminally. In this kind of very high-grade stenosis, I would prefer to make a pre-dilatation, because we know this is now the question, which size of shockwave should we use? So we know we have to oversize the shockwave balloon catheter around about 10%. That means 8 millimeter shockwave, which is now available for big vessel disease And in this case, I would take 8 millimeter shockwave for the CFA, and but also for the SFA, maybe, but only with 2 or 3 atmospheres. Would you agree with this sizing?
Raphael?
Yes, totally. We need some oversizing, and we have 8 millimeter balloon now with the last generation Shockwave M5 Plus. So I would go for the 8 millimeter, not too much pressure, and you can use it, as you said, 2, 3, or 4 atmosphere pressure, and then you can use the sonic waves. So yeah, it looks great. I would do that.
Okay. So Elias, when you're working now, my question is, what about the crossability of the shockwave? Please go forward in order to be on time. And if you can, please answer the question. So do you think that is a good device to cross this kind of lesions? You don't need to go to do predilatation, you told us.
So in the majority of cases, I would say the profile of the shockwave balloon is really very, very nice and very well. But sometimes in this kind of lesion with a eccentric plaque formation, so I would prefer to make a predilatation just to avoid that the balloon catheter
will rupture.
That isn't possible, to rupture exactly. And as you can see, so it isn't not really easy to cross with a very low, that's a 3 millimeter balloon, to cross the lesion. It's a very tight, yeah, now is it? And maybe as you can see, that's a very eccentric plaque. And this is now only by 8 to 10 atmosphere, just to have a channel for the Shockwave Balloon. Kannst du mir jetzt bitte den 8er Ballon geben? Den Shockwave, ja? So once again, at the stand edge.
So in order to have, let's say, some good advices and to highlight the features of the device, especially for the beginners of using this device, it is clear that we don't have any risk of embolism during the angioplasty with shockwave. You have not seen in any case, or there are some cases that we may use a distal protection device? Elias.
So I never seen a peripheral embolization after shockwave. So in the last, let me say, 4 or 5 years, we made a lot of cases, and we have not seen one case. But I know that in the observational study, so there was reported less than 1% of peripheral embolization. But in our center, in our institution, we have never seen it. And one point more. So as you can you focus now at the shockwave? So maybe you can describe this balloon catheter. It's I will start. It is a 0.14-inch compatible balloon catheter with a very, let me say, so low profile, very nice balloon. And it's a OTV balloon catheter, and the package of the new device, M5 Plus, indicates it requires a 7 French sheath. So it is not really necessary to take a 7 French sheath for the shockwave balloon. So in this case, I will take DCB, an 8 millimeter DCB, which requires a 7 French sheath. So you can insert this balloon catheter, the 8 millimeter balloon catheter, also during a 6 millimeter, 6 French sheath, sorry. So as you can see now, there is a there was performed a pre-dilatation, goes downstream a little hard, but it isn't, it's okay, it's okay. So,
I
and
think
the
it's
next step
important here. I think it's important here to mention for people who have not used it. I like where you place the balloon. So that most eccentric plaque or the most stenotic area you put the balloon. So the two center emitters were on it, which are the most powerful, rather than using the edges of the emitters. Can you make a comment on that?
It's very important. So that's we know that the middle part of the balloon catheter, the emitters, has the most power, and in this case, I would place it exactly in this position, and I will give two shocks, the 2 cycles. That means 1 minute in the same position, and I will pull it back for 1 centimeter, and then try again to cover the complete lesion from distal from the stent. So the next step, as you already maybe see it, it's very important to deflate the balloon. There is a lot of bubbles, and it should be bubble free, and it should, you have to take a diluted contrast media. That means 50% maybe natrium chloride and 50% contrast, and it should be completely bubble free. So there is also a sterile cover for the device.
Until you prepare it, just to summarize again the advantages of the new M5 Plus. So you're talking that we have a quicker 6 cycle time, so it is faster than the normal one. We have compatibility to 6F friends for the 6.5 and 7 millimeter. Only the 8 millimeter should go through 7 friends. And it is actually, we have now a broadened access option because we have a length of 135 centimeter of the shaft. Is that right?
Exactly, that's correct.
Oh, perfect.
So I will go now just with...
Okay, go forward, please. There is a question from the audience. They're asking how many times can you do an IVL angioplasty at the same point in a vessel?
So in the majority of cases, it's necessary maybe 2 or 3 times. But so sometimes if there is really a very hard calcium, I already used also 4 and 5 times. There is no, I never seen a problem or a rupture of the vessel.
Okay.
So we can see now very clearly the high-grade stenosis. I have to make one deflation. There is a bubble at the distal part of the balloon catheter. Just to be sure there is no bubble.
Rafael, I think in case of using Supera, or let's say because these are the dedicated stents for this kind of really calcified lesion, I think it is a must to use this shockwave as a vessel prep method. Is that right?
No, I don't have a lot of data to support that IVL is really the best preparation for Supera, but that's now our practice. Because then you have a better preparation for calcified lesion, and then you have better deployment of the Supera. And it has been shown that the good deployment of Supera is associated with better results. So yes, my strategy currently is that if I have good preparation, then I use DCB. But if the preparation is not perfect, I have dissection or whatever, then I use Supera.
Elias,
what about yours, Theo?
I will use it in calcified vessel in any case, regardless the kind of stent. So I will try, if I have a lot of calcification, it is my first option because there is no other way to crack and to open the vessel, in my opinion. But the point is, this is a really challenging lesion. You see here how difficult it is really to open the artery at the level of the eccentric lesion. So Elias, what do you think?
It's correct too. So in this kind of lesion, I'm sure that we will need there a very short supera. As you can see, this is now the third cycle of the shockwave, and we have some luminal gain, but there is a tight stenosis, and I don't like to go a little more or give a little more power pressure because I have now the 3 atmosphere, and that is a little too oversized, or will be a little too oversized. So the next step will be to 8 millimeter. Yes, that's the 8 millimeter balloon. So the next step, I would take a maybe 7 millimeter and try again, and then I would make here a second.
Are you trying to use this same balloon for the common femoral? Is that why you're not maybe using all the cycles down below? Is that a cost issue? Because there's really no, there's no contraindication to using more shocks in that SFA lesion.
Yes, we know. So that's a riddle. Also, the problems in Germany, there is we don't have a reimbursement for the shockwave. And in this case, I would take the same balloon catheter also for CFA, as you can see now. So that's also the reason to try to give some or treat all the lesions with the same balloon. At the moment, we don't have a reimbursement, so hopefully we would have this in maybe 2 or 2 years.
Yeah, so if you just had that one lesion down the SFA, you would have probably used more pulses down there. Is that correct?
Yeah, exactly. That's correct. And as you can see now, so in the femoral artery is the balloon completely open. So that means there was not really or the distal calcium was really much higher. But in
Elias,
this position, yep.
Mike, there is a question from Mr. Gonzalez Florian, who's asked, why not using a non-compliant balloon in the SFA?
Of course, we can use it, but the reason for rupture or perforation of the vessel is a little, or the risk is higher, and also dissection of the vessel. Another option is also to cover the lesion with a covered stent like Viaban and make a high, or take a non-compliant balloon and make a high pressure balloon angioplasty, like which was described by Andre Schmidt from Leipzig, So that would be also an option, but my primary strategy is as first to treat the vessel with a DCB if there is a necessary or a residual stenosis. So I would cover this with a supera stent, but I would see it now. Let me just give one shock more, and then we can check it.
Well, I must say that the IVL of the common femoral artery really looks quite good so far.
Yeah.
Okay.
I give you a light. So.
Frank, in case that you need to use in the US the shockwave and you have a concomitant lesion in the deep femoral artery. So what are you doing with the size of the vessel? How are you working? Are you working with the same balloon or using two balloons?
Well, I mean, you know, we probably don't have the same constraints as they have in Germany, but we do try to still remain cost conscious. So if we can get by with one balloon, we certainly will. But there are times where I certainly have used two balloons in a case, and you know, you're probably better off doing that rather than creating a complication which is associated with probably many more costs than just opening another balloon personally.
Raphael, what are you doing in France? I know you have the same problem like in Germany.
Yeah, we generally use the same balloon, and it can be the same balloon that is in the CFA with the distal part in the PFA. Since it's low pressure, I don't think it's a huge problem. We can have an 8 millimeter in the balloon in a 5 millimeter profunda. We just inflate it at 2-3 atmosphere, and then we don't damage the profunda that way.
So let me
I have
give
a question.
you an angiography. Yeah.
Can I ask you a question? You know,
Yes, of course.
IVL create microfracture in the plaque, and so it modified the nature of the plaque. But sometimes, as probably it will be in the distal SFA, we don't have a perfect result, and we need to add another preparation tool. What do you use in these cases? You use POBA, high pressure balloon, something else?
So as a vessel prep, I would take not a balloon catheter, a POBA, but for a treatment, I would take a drug-loading balloon or drug-coated balloon. Kannst du mir das bitte aufmachen?
Very nice result, Elias. What do you think?
Yes, it looks really very nice. Das ist ja bitte zu. Kannst du mir das aufmachen? I give you a second oblique. Nee, das da.
Yes.
Ich habe kein
Very
Kontrollmittel.
important. Very important.
Nein, das ist zugemacht. So, jetzt. So, second oblique. Okay.
Wow.
So there
very
is
good.
no dissection. It's a nice result. And at the distal part, I will expect that there is a residual stenosis, maybe. Which I have
in my opinion, this will be enough to treat the symptoms of the patient, because the deep femoral artery now is nicely open and has more flow. But of course, you don't want to risk the patency of the stent. So I think you have to do something in the SFA.
Yeah. So the next step is first just to cover now the CFA with a 8 mm DCB. Kannst du mir jetzt den geben, bitte, mit kurzem Schaft?
So
did you
DCB,
use the pulses of the Shockwave? Are they all out?
Completely, 300 shocks.
Okay.
so guys, DCB after IVL, we have some data out in the literature. Raphael, do you believe in this? Should we do this?
I believe in this because I try to avoid stenting when I can in this very calcified lesion, because if the stent is not very well deployed, then you have other issues. I'm concerned about this case and this image in the SFA. Honestly, I don't know if we can let it like that. The patient is Rutherford 3, you said, so it's not. He doesn't need so much lumen opening, I would say. How do you approach that? What do you think?
So I would take now a 7 mm balloon and make a second vessel prep just with a pre-dilatation, just to check how is the compliance of the vessel after shockwave, you know, just to be sure.
Now, this is the DCB, or what is this now?
This is now a DCB for the common femoral artery. And then
So
I
the
would
sizing is now 1:1 with the shockwave. Is that right?
Yes, this is a 8 mm, 8 by 60. impact balloon catheter. And I will leave it for 3 minutes.
Elias, you have a huge experience with this stuff. The question is, did you have any case where you were subintimal during the recanalization of the CFA, and what are you doing in this case?
So I already use for heavy calcification also Shockwave, and in my opinion, it works. It works very well, and I observed that the compliance of the vessel is much better. So just for example, for cases with Supera, I already done a lot of cases vessel prep with Shockwave, also for subintimal recanalization, and then covered the lesion with the Supera with a nice expansion of the Supera stent, you know.
Frank, same opinion?
Yeah, I agree. I think his thought processes are sort of spot on. I do try to avoid stenting the common femoral, though, if I can.
Absolutely.
So we have 2 minutes still, and then we will come back to you to see what you have done with SFA, because we have some really nice presentation from Frank and Raphael. Until we have the final intro, Elias, 2 questions. One from Gustavo. He's asked, the last inflation was at the femoral bifurcation. Should you take care about profunda occlusion or not?
So I never seen that. No.
Perfect. Clear answer. And Raphael, for you a question. What kind of antiplatelet treatment and regimen are you going to use to this patient, IVL plus DCB, when you don't need any standing?
Excuse me too, I didn't hear the question at the beginning.
Which kind of antiplatelet treatment? So aspirin plus clopidogrel or aspirin alone? What is your recommendation?
I always do double antiplatelet therapy after such procedure. But it's a belief.
Regardless stenting or not, is that right?
Yes, regardless. Whatever.
Okay, and for you, Frank?
Same, I would use dual antiplatelet therapy here, and then also make sure that we've got the high dose statin on board, which has been demonstrated to, improve patencies as well. So I think it's more than just the antiplatelet. I think statin therapy is equally important.
Very important message. Elias, what are you doing now?
So this is now a 7mm balloon, and I would make a dilatation. Es kann sein, dass Sie jetzt ein bisschen spüren.
Oh my God.
Yeah. So, but it looks much better. So it's the
compliance seems to be a little bit better. That's right.
Yes. I'm sure. Yeah.
So, Elias, when you're ready, please give us an angio result from the CFA, just to see what happened there in order to go forward with the presentation. And then we'll come back to you at the end. Yep.
Let me make a second dilatation.
Yes, sir. Raphael,
it certainly looks like the compliance changed a lot on that lesion right there.
So I give you now an angio for CFA.
Let's see if we can convince now the 75% of the people that they have voted against IVL. Very nice.
So there is some calcium, but there is no residual stenosis or something. Of course, there is some calcium, but the result is
very nice. Frank, are you happy with the result, Frank?
I am happy. It's got good flow. It's got good filling of the profunda. It's got rapid washout of the contrast. So I would probably be done here.
Mit Langsamschaft, Pacific impact.
Elias, first of all, thank you very much for the amazing presentation. We will come back to you at the end in order to see how you solve the problem with the SFA. We're coming back now to Raphael, and Raphael will talk a little bit with some case examples about CFA. Raphael, please share your presentation, and thank you.
Okay, thank you. So here is a patient that is 80-year-old. He has a quite disabling claudication on the right side, and he has this tight CFA stenosis on duplex scan. This guy is not that high risk, but he has anticoagulation therapy in the long term for heart tissue. So here is the axial imaging and the 3D reconstruction, and I can show you also the CT scan. It's quite slow, but you can see there is no significant proximal disease, perhaps a little bit calcium on the right common iliac. The internal iliac is occluded, and we have this lesion that is just ending above the bifurcation. I can show you just the lesion once more. You can see here the right CFA lesion, and then this aspect, and below it's healthy. So my question in this case is, how would you manage this lesion? Theo, Frank, do you want to give an opinion?
Frank, please.
Yeah, it looks like to be a heavily calcified lesion. I think that it probably would go to, let's see this come through. It's coming down that it's heavily calcified on it. We're talking about the right common femoral, right?
Yeah.
Yeah, it's heavily calcified there. It sort of looks like it extends almost down to the orifice of the profunda. Again, as a vascular surgeon, I think that open surgical repair would be reasonable. He's pretty advanced age though, 80. That's not an easy operation to overcome. So I think an endo first approach here is certainly reasonable. And if you have problems, you can always go back to open endarterectomy.
Yeah,
same for me.
So that great. So we have the same opinion. In this case, just for the youngest practitioner, it's important to note that the profunda and the SFA are really in the same axis, and you can see here on the view. So it's really important nearly to be in profile view to see the bifurcation. So we go through the contralateral side. We go for strategy that will be vessel preparation with IVL. The CFA is around 8 millimeters, so we don't have that much choice than to use a M5 plus 8 millimeter catheter. You can see here the low flow in the profunda. So we try to put the wire in the profunda first, because it's really the artery to preserve and to open. And we bring the 8 millimeter IVL balloon here, and we inflate the balloon at 4 atmosphere, and we use overlapping technique to inflate the balloon a little bit everywhere in the CFA. And you can see, as we discussed earlier, the distal part of the balloon is really in the PFA that is quite large here, but I would do it also with a smaller PFA. And then we have this result of the preparation. I would like your opinion here.
Well, I gotta tell you, I'm very impressed with the completion angio here. It looks like you just did an endarterectomy, to be honest with you, and you've got still good flow going into that SFA. I would be, in an 80-year-old, this would be a case where maybe I might consider like a buddy wire into one of the other vessels. I really like your technique here, to be honest. I'm not sure I would have done it that way. I probably would have put my wire down the SFA because it was open and widely patent, and maybe done a buddy wire into the profunda. But it did look like the calcium extended into that profunda, and I really like this result here. I like the result. I like the technique. And it's it's probably one of the best IVL cases for a calcified femoral I've ever seen.
Absolutely, Raphael.
you.
And the point is due to the fact that you have very low embolization rate with a shockwave. Actually, you can. I'm always a fan of putting the balloon where the lesion is, regardless if this is the deep femoral or in the SFA. I really like what you have done.
Thank you. Just to answer the question about the body wire, usually I don't use body wire if the bifurcation itself is not involved in the stenosis. Here we can discuss. It's true because it's really at the limit of the bifurcation. That's why there is just a wire in the PFA. But I fully understand your points. And then we use this DCB size to size 1-on-1, and we still have the same results. So this guy is really doing well after. On the duplex at 1 month and now at 3 months, I think. So it's really one of the best results we can have here.
Yeah, I will say that when I was younger, I was a little bit more likely to put in a buddy wire. I mentioned it only because someone, is usually asking the question about a buddy wire. But I would say that in the last 4 or 5 years, I've gotten away from the buddy wire as well because one, I haven't had the issue of shutting off one or the other vessels. That's number one. Number two, if I did, I feel pretty comfortable that I could get into the other vessel, either from the antegrade, or if I had to, I could go pedal and get back into it. I haven't had to do that. But the buddy wire, while it sounds really simple and easy, you've got the 7 French here. You probably can't get the 8mm balloon through the sheath with the addition of the buddy wire. So sometimes you have to upsize the sheath, but it is an option for those who are concerned about that happening.
The strategy you mentioned with the retrograde wire is really a strategy I love to use also, and it's important to mention. Thank you.
Okay, Raphael. So let's have now a second scenario, and this scenario is coming from Frank. So here we have seen a de novo lesion treated by IVL plus DCP. Frank, you're going to show about redo in the area of CFA and why to use their IVL.
Yeah, talk to you a little bit about the patient history here. So a 75-year-old female, left leg, claudication, peripheral arterial disease, dropping ABI down to 0.6. Really, she's trying to be a bit more active and exercise, and this is really her limiting issue. She's got diabetes, sort of consistent with the heavily calcified lesion. Prior smoker, but not currently smoking, so pretty compliant on maximum medical therapy, including aspirin and Plavix. So here's the common femoral artery stenosis, just distal to the bypass graft. So it's a pretty interesting lesion. So this is a redo patient. I did not actually do the original bypass here. The bypass is actually open. There is a stenosis in the distal aspect of the femoral popliteal bypass, but you can sort of see here this lesion, if I can get it to play. There it is again. You'll see here the common femoral itself is diseased proximal to the bypass, and then the profunda femoral itself is also quite diseased. And I was a little bit fearful here of just treating the bypass graft and leaving the profunda alone, because if that bypass graft went down, she would become quite ischemic, I think, quite quickly. So again, there's that lesion there. So again, sort of got left femoral access. Went with Shockwave, the M5 plus, 4 times 60, did 3 rounds. And then exactly like he did, some DCB of the common femoral and the profunda femoral artery. And you can sort of see this end result here. So again, first treated the distal, this should play automatic, but first treated the distal popliteal graft, but you can see here, very nice result of that profunda femoral artery, and then even the more proximal common. So very similar to the last case where the SFA was occluded, but was able to stick the balloon all the way down into the profunda and really get a nice result. And I did not put any buddy wire into that SFA or that femoral popliteal graft to try to protect it. I thought the risk of me embolizing down to that was going to be relatively low. So this is the pre-angio over on the right side, and you can sort of see the completion angio on the other side with very good filling of the profunda. Really, all the branches stay open, and the common femoral itself looks quite good. So, you know, we really believe that IVL is a safe to modify calcium while reducing the risk of complications. I really have not seen much in the way of embolization myself. I know there's, you know, very small incidents in the clinical trials. It's very intuitive to treat these lesions. It's safe, it's effective, and it's relatively quick as well.
Frank, in this case, you have used a 460 balloon catheter. My question is, have you used it due to a measurement with IVUS or with ultrasound, or it was just you know, a feeling?
Yeah, I had IVUS her, and she was quite a small woman. That vessel was measuring about, I want to say it was only measuring about 4 millimeters. I didn't do the original bypass, and I think what they did is they just sewed the graft directly onto the common femoral. It was probably pretty heavily calcified. Had I done that bypass, I probably would have endarterectomized that whole common femoral and then down into that profunda femoral. So I maybe could have gone a little bit bigger with the 5, but, you know, I did not want to dissect the couple things that maybe I undersized the balloon a little bit. One, I felt I could go bigger and go low pressure, or I could go smaller and go high pressure. I did not want to dissect her. That's number one. Number two, I did not really want to, if I had to salvage that profunda, put a covered stent across it with the SFA coming around. So the reason to go after that profunda was in case the FemPop bypass graft went down, and that's sort of why I did that. But that distal profunda was measuring right at 4 millimeters.
Perfect. Now we want to see your iliac artery case, but let's see the results of the poll. Please, Sebastiano, show us the result. Is vessel prep important in the iliac vessels? 86% says yes. So can we see how it goes, Frank, from your cases? Rafael, do you agree?
Yeah. Let's take a look.
Rafael, is important for you vessel prep in the iliac vessels?
To be totally honest, I do not prepare the vessel if it's not calcified in the iliac. I do primary stenting to avoid emboli because in the non-calcified lesion, I had some emboli several times. So we have to be very careful about it. But if the lesion is calcified, then I think that vessel prep is extremely important in the iliac because we have all seen this aspect of under deployed, under open stent in the iliac. So yes, if it's calcified.
Frank, go on.
Yeah. So here's a case. This is a 78-year-old woman whose sons are all cardiologists. She's got worsening claudication, really quite severe. She was really not interested much in the way of any interventions. So I first tried treating her with even more advanced medical therapy. I added Xarelto in combination with aspirin, but over about 3 to 4 weeks, she just had worsening pain. Here's her CT scan. You can really see she's got pretty heavily calcified iliacs. I think that's the biggest problem. She's got this sort of tapering aorta that's heavily calcified. The externals are a bit diseased, and you sort of lose what's going on there. The right common femoral artery was nearly occluded, and with that, I elected to do a endarterectomy with patch angioplasty on the right side, but then everything else was percutaneous to treat the iliacs. With this very small aorta that's heavily calcified, I was a little bit fearful that she would be at a higher risk of rupture. So I felt more comfortable with sort of going in there and pre-treating her with IVL over the covered stents. So you can see here that this doesn't look that bad, but I can tell you it was quite difficult to cross those two lesions within the vessels. And you can see this is the area of heavy calcification on the left side, and then a very short focal lesion over here on the right side. and she was quite calcified all the way up above that, but frankly, not that stenotic. I also was a little bit concerned about her distal disease, and I didn't want to really raise the bifurcation in this woman too much, because I felt that there might be the need to come up and over in the future. So that was sort of my thinking. We do a lot of IVUS. You can sort of see here, this is the right common iliac and the normal vessel. So her normal vessel is measuring about 6.4 to 5.8. You can see in the right common iliac, in that very short segment lesion, she drops down to about 2 millimeters. This is an 014 IVUS, so it's basically the size of the catheter is the lumen. Went ahead and measured the left side again, so you can see it's a pretty small woman. You can see these are the common iliacs measuring just at 6 millimeters. So again, if you go very aggressive with these lesions, and my goal here is to try to put in 7 millimeter covered stents, which I think with this amount of calcium, if you do that, I think there's a risk of calcification in this sort of small, somewhat frail woman. So went up with the kissing 6.5, so a little bit of oversizing there, M5 plus, used the totality of the 300 pulses on both the right side. I used 2 balloons here. Maybe you could have gotten by with one on the left and then moved it over to the other side. And you would have saved the balloon, but maybe would have dropped the pulses that you had down by half. And you can sort of see these balloons going up. I can't see it because my little windows, but you can see them going up. I did keep the balloons up a little bit high in this, but I didn't think I was going to create any sort of dissection. Again, the 2 emitters are in the most heavily calcified regions. You can really see those open up and the compliance really change. So again, while my balloons were pretty high, I kept the stents not that high above the aortic bifurcation. Most of that disease was within the common iliac. So I think I'm going to have the ability to get up and over this aortic bifurcation in the future if I have to. I did oversize these. Remember, her vessels were measuring just at about 6. I'm not super comfortable with putting 6 millimeter stents in the common iliacs. I think they have a high rate of occlusion in both men or women. So my minimum here is really to try to get to 7, even if the vessels are 6 or 6.5, but you have to go slow. And I think that this IVL really allowed me to do that quite well.
Now telling that what is happening in Germany, let's go back to Germany to see what he has done. Elias, can you hear us?
Hi, Theo. I can hear you very well. So I can show you the results of the SFA. So I already prepared this with the 7 by 20 millimeter balloon. And now you can see the DCB. As you can see, the DCB was really very well expanded, completely open. And that's what I mean. After IVL, we will have a better vessel compliance, And the result, that is now 7 by 60 millimeter DCB. And the result looks really very nice. There is a very small or a less residual stenosis, maybe 20-30%, but it is not really relevant. And the next point is also very important. This is now the CFA just 10 or 15 minutes later. There is no recoil, So that was just treated by IVL followed by DCB with a nice result. And also some later, a second oblique of the SFA with a nice result without a stent. And as you can see, the reconstitution of the below the knee arteries is now much better, much faster. And also refilling of the distal part of the below the knee arteries, plantar arch or dorsalis pedis, it's much better, much higher, much faster. So I would say that's a nice result without a stent angioplasty. So that was my intended treatment to avoid a stent angioplasty, maybe at the distal part of SFA or proximal part of popliteal artery, which is a landing zone for a femoropopliteal bypass. And I'm happy with this result. What do you think?
Elias, I have to say, this is the definition of vessel preparation. Wherever you look in the literature, what means vessel preparation, it means lumen gain, and it means improvement of the compliance of the vessel in order to have better uptake of the paclitaxel or of any drug. So really respect is an amazing, amazing result. Thank you for this. Frank, are you happy?
Yeah, I think a very nice result. I think there's going to be a lot more flow getting down to the foot. I think, you know, I didn't see the patient pre-procedure, but I suspect that the claudication that they have is going to be markedly improved, and you can continue to watch that popliteal occlusion.
Yes.
Yes, makes sense to you, because this is a question from Dr. Patrone. Does it make sense to make a duplex in the common femoral artery? I mean, not now, but if you're doing it during the operation to see the change of the monophasic or biphasic to a triphasic flow?
Sometimes we do that, but not usually in every case. But of course, yes, it's a very nice option just to check and see a change of the flow from mono to biphasic, of course, yeah.
Guys, unfortunately, we are at the end of the session. Actually, we could talk together hours and hours about all the nice advantages of the Shockwave, and especially the new device with an 8 millimeter diameter. So we have seen a very nice presentation of the device live from Dr. Nori from Bad Krozingen, where you have seen how it works in the CFA, and also sometimes you need an additional work in a very eccentric lesions. I really like that he highlighted that Shockwave is not only for lumen gate, but also for changing the compliance of the vessel. So Rafael, the last word for you. Do you think that we have a game changer, or it is the gold standard now in the calcified vessels?
I would say yes, and especially in these very short, very high calcium load lesions, as the one that were shown here. So yes, we have something that changed the practice here, and actually in our center, it's now first-line preparation tool for very calcified lesions.
Perfect. So guys, Frank, thank you really very much. Our best regards to the US. You are on green, that means you are still working there. Enjoy your day there. Rafael, thank you very much. Best regards to Paris.
Thank you.
Ladies and thank you very much. Elias, you are a great operator again. Thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye. Bye-bye.
Bye, everybody.
Thank you. Bye.